here again, sorry for being boring with me. and I will just a little bit talk about what is the advanced practice in nuclear medicine. It was a joint project together with KSNMMI here, and you can see also Peter Hogan, Christian Waters, and Rees as co-author of this job. No disclosure. So, well, here's the overview. We have a background to state, the UK perspective, some definitions on that, rationale for advanced competencies, how is we can implement advanced practice, how to build a clinical career letter, some real examples of advanced practice, and some difference between countries. And then what next? We will see what's next. So, here, some background information. Well, a start, we are not saying to which country if they have to should or not attend to advance their practice. This will be left to every country to decide. It's not a position document about that. Well, we want to encourage nuclear medicine technologists and radiographers to take a critical look at and evolve where possible their professional roles. Main important, this talk is about acknowledge what we are doing and what can be done, and what is done in other countries. We tried to build a Euro-American consensus, and we tried also to provide a framework for national ambition on how to develop a career ladder, and we tried to learn from others. So where we started? Yeah, what we did. We started in 2009 building a working party together with the EANM technology session. We wanted to produce a discussion document on it with a primary focus on advanced practice and a secondary focus on entry-level practice. We created the draft document in August, and then we consulted other people with this procedure to ask them what they think about it. We wanted to build a consensus. We didn't want to do a all-world document. We stated on Euro-American mainly due to the because it was easy to have just two parties working on the document, but we wanted to learn from all the world what they really think about this document. And we can also say that this is a consultation exercise of our document. So you can say there are professional groups involved in the working party with both physicians, radiologists, technologists, radiographers, and also university staff. Here are the people that were involved. And you can see, just to tell you, professional work. Frank Knapp was the president of EANM. So it's not a thing made only by technology, but the doctors were really involved in the project. Not just a consultant, but involved in the project. So we started from a UK perspective. The point came from there, and how you can see how evolved the procedures were made by technologists during the years, starting from a really low profile to high professional status in the 90s and then 2000. While in some points, in others, they just kept us low, they increased, but not so much. We'll show you why and how. So, well, you have to think that in the UK, before 1990s, there was a lot of boundaries between radiographers and radiologists. After 90s, this boundary starts blurring, and there was a significant overlap. And then a new grade introduced. What does it mean? That there was a lack of radiologists and nuclear medicine physicians in the UK. That's what will bring hospitals to ask technologists to do more and radiologists to do more. What does it mean? That we created a new, in UK, they created a new figure of more specialized technologists, but there was still some job to be done. And also there was a less specialized category as technician that came up to doing the less specialized work. So, what do we create? Hybrid professionals. Some radiographers only worked in some zones. For example, this one, this interact with the physician works, was the main competence for some of the radiographers working. And some technicians also worked in the same, well, as advanced radiographer or technologist. That's quite a tricky issue. Some definition. We tried to find a definition of entry level and advanced practice that could be good for everyone. So we did it. Entry level, a competence and skill set that is considered necessary to ensure that nuclear medicine procedures are conducted to an appropriate level. Must be obtained during basic training. May vary really due to national regulation. And well, any agreed international entry-level list will be kept small, because if it really education may vary a lot between countries. So we go on to advanced practice. What does it mean with advanced practice? Advanced practice must be obtained after the basic education. Must be an higher cognitive and clinical level than the basic training. So we have to do not more competencies, but higher level competencies. Must be done to improve patient care and management. To offer clinical career progression opportunities, must be some rewards for the taking new responsibilities. And can really vary widely. So, moving towards an international model, we have a single country view, so an entry level with basic trainings, and then advanced practice a little bit higher than entry level. What can happen? Sometimes there is an entry level that present novice and experienced staff. There will be difference in capability, there will be difference in proficiency, and who is dipping into advanced roles. What does it show? It shows that sometimes you have people inside the same department that really know things different and are really able to do things different, but they are quite at the same level, so they are still considered entry level. That's a situation that's happening in a lot of countries. So what we tried to promote an international view, so differences in roles between entry levels, and advanced practice that might not exist, not necessary to have advanced practice, but also there will be different roles inside advanced practice. So we tried to build, since there is a potential of conflict with this model. For example, where do we place a role that is advanced in one country and entry in another? It can happen. So we tried to build build a model in which entry level is smaller. We had a advanced practice one that is sometimes it's basic training country and sometimes it's advanced practice. And that's also a higher ring that is considered advanced practice almost everywhere. That's why we build this kind of model. Take it as a knowledge model. It's about a cognitive model of what is going on. Well, rationale is having benefit to patient, professionist, and the service. So this is really the rationale for that, for having advanced practice. We have to increase the efficiency, increase the quality care, and important for the pathway with limited access to doctors. That's what I told you before about the UK. Well, we have to define a clinical career ladder, and we have to find we have to legalize the procedures. Must be a financial reward and higher job satisfaction. That's what's going to happen. And the service can improve efficiency, better use of staff capability, and have a reduction on cost. Technologists may cost less than doctors, sorry to say that, but can be also nice for some problem with a lack of doctors and lack of funds. Well, there will be many barriers and facilitators to implementing advanced practice. And people with effective leadership can turn the boundary into facilitators, overcome the barrier, and make good use of facilitators. Here are some facilitators and some barriers. You can see that. For example, short of doctor is having key players, or make effective use of potential skills, role models. But here, all the barriers: laws, litigation, fear of change, fear of losing money, conflict of roles. Well, where did we found that it was the possibility to really go into advanced practice? When doctor asked technology to do it. That's really one of the main facilitators. Main barrier was when doctors don't want it. That's where the main barriers that we faced in discussing it. So what are really ask from effective leaders? To really be aware of the greater role and really be proactive for people and for technologies to advance, and also not want to be in the limelight, but also to share there with other people. So how we build a clinical career ladder? Experience plus entry level, going into advanced practice, create a low responsibilities professional status, and then maybe in UK it happens they went into consultant practice. Some of them were able to. Example of this is quite amazing. Look at that. These are quite some examples of what we talked about advanced practice. Scanning the patient. In some countries, advanced practice is scanning the patient. Processing the images can be advanced practice in some countries. Patient care can be advanced practice. Performing equipment and quality controls. Some countries, some of the work are not within basic training, but they are advanced practice. And may be obtained, but not. So some people that will never scan the patient and be a technologist. It happens. We find it. So, strictly speaking, they are all advanced practice of what they are talking about. And we faced it consulting with other accounts. So, well, we talk about having a minimum requirement for entry level after we solved it out. So we state, okay, we try to have a realistic but optimistic view. So we state the level of entry level a little bit higher. So here are some examples. Medicine management can be a potential advanced practice world. Non-medical cardiac testing. This is really common in the UK. I met some people that actually do that. They were technologists and they actually do that for job. Their job is that. It's not remote scanning patients, but they are doing medical cardiac testing. Requesting X-ray. This is quite tricky because, well, it's just about reporting. So for example, you do a bone scan, you find a strange role, and you ask for having a X-ray scan. It happens. It's called a report finding. It's a talk about report finding. It's not a diagnosis report. It's a report of the findings. This one is quite tricky because it's advanced practice, but well, actually I do it. So identify nodes and nodes on scan for lymph nodes is considered advanced practice in many countries, but in Italy it's commonly performed by technologists, for example. They are just examples. You have not to think. But all the examples are taken from reality. So in some realities, it happens. What I was talking about, a report about the scan, description of what is seen. So you just describe what is found. And can be providing an answer to the clinical question, suggesting what next. Informally, in some countries, it happens when you talk to the physician and ask, what do you think about this scan? Sometimes it happens, but it's not formalized. It's not legal, for example, in most part of countries, not legal. Radionuclide therapy sessions can be led by a technologist. So where is the bridge? We point also a limit. Well, interpreting X-ray and nuclear medicine imaging are not our job. That's what we wanted to state. Complex procedure is not our job. And the question is, at what point you need to be medically trained? What is the point that finish advanced practice and start medically works? It's quite difficult to sometimes in some countries to really understand. So, what I want to state, what the central requirement is service improvement. So everything must be motivated for improve the service. You have to establish clinical benchmarks. You have to engage in evidence-based practice, research findings. What does it mean? You have to show that you are really able to do that. And the value of clinical leadership, because you have to make a level of clinical decision and you have to need more autonomy in your job. Encourage research, establish best practice, guidelines, and standards of care. It's easier to go into advanced practice if you have standards of what you are doing, because you can follow it, and standards must be agreed inside of the department. Self-audit, work of nuclear medicine technology working together, and collection of publication for outcomes. So we have to show that doing advanced practice, you are doing a good job for patients. Teaching can be also teaching medical staff. It happens to me to teach some medical students how to we perform a renal scan. Once it happens also to me. It was a case. Maybe it can be a good point for starting to go into advanced practice. Professionalism. To go into advanced practice, you have to know what you are doing and to know what very well what is your role, and have a good communication skill. That's really important. So what can differ between countries? Educational, legal issues, scope of practice, and the social acceptance for new roles and responsibilities. This can really hit hard on maybe a lot of people are not accepting this. Where we arrived here, a Euro-American discussion document on entry level is downloadable. It was published in Journal of Nuclear Medicine Technology, and it contains mainly what we have written here. Just think, these are a cognitive model. We taken from practice what we think would be a possibility of advanced practice. It's not a position document. It's something that we want to discuss about. And then later on, we will discuss also some other applications. Thank you. Want to? Or you want to also the next one? Are you sure? Okay. Okay. So just please. I know that's quite boring to hear always the same relator, but keep in mind this presentation for the next one. Keep in mind what we are talking about, because in the next one we will go to a further step of it. Here we were. So, no, well, what we are at the point, we built a cognitive model. We say, okay, we can move on with this. And that, what we do. EANM, as a whole, is not a professional association, neither a professional body. Individual committee, like our committee, may not have a professional role, but we cannot hide ourselves. So everyone is asking us to please discuss about competence, so we have to do it. And EANM and committee's position may be shown only as guidelines and can be proposed to national society. National society may use EANM guidelines to lobby legislative body for updating competence, or may not. That's the main problem. We give another example. For example, KSNMMI technology session. Is more than 8,000 members. Is quite the goal is always advance professional for technologists, and also give them legal assistance, research support. They want to be recognized as leader. And well, what's the most important? KSNMMITS is a professional body and not only a scientific association. EANM Technologist Committee. It represents is quite a scientific committee inside European Association. Around 300 technologists members. We represent nuclear medicine technology inside the association. We encourage technologists to join EANM and to broaden their horizons. We want to promote high standards for daily work in nuclear medicine technology in the different countries. We want to assist the development of high-quality national system of education and training for nuclear medicine technology. We want to participate to wider EANM initiatives on education. We want to work with other committee and also organizations to ensure that technology's important role in nuclear medicine is acknowledged and developed. We want to promote and contact exchange information within the National Association of Technologists in different countries of Europe. What does it mean? Well, it means that we are part of a bigger wall. You can see the member that we were at the moment with to prepare this discussion. As you can see, we came from all different countries of Europe, then Germany, the south to the north, to the Central Eastern Europe. What does it mean? We are a scientific committee. We are considered as much as the oncology committee, as much as the OED. But we also have some other duty to carry on, and the duty regarding the profession of technologist. The difficulty is to bring all together, because we cannot go step by ourselves, but we can lobby EANM to take steps on this point. Where we were, you have already seen this slide, and what to do now. State of the art. The Advanced Practice Discussion Document is an excellent intellectual instrument for building subsequent works. We had the previous EANM position documents of technology competencies, but were old and not consensus based. So that's a big problem, because we did some quite a good job. The people before me did a quite good job, but they were just self-standing. It was not a consensus job. And the most important thing is no one knows about it. And that was the worst part of it, because not knowing that, no one will use it for improving technology professionals. So, well, what we can do for have a real impact for the position document for technologists. First of all, we look at the Americans, because we already had the project together, and, well, they wanted to continue the work. And we had two firm points. Start discussion on basic planning and find a way to give our words a real impact on daily practice. And use a realistic, optimistic point of view. What does it mean? We don't want to state that all people must go, all technologists in the world must be advanced practitioners. But we want to use a realistic point of view. So, for example, scanning the patient must be an entry level. That's the point. So, our intentional work of our competencies, we want to create a competence document that can be read, be used, help effect change, have professional recognition and status, improve practice standard, improve patient care management, and help harmonize practice standard. That's what we wanted to do with our next project. What happens? Discussions. In USA, well, maybe James can agree, nuclear medicine associated graduated, but was not fully embraced due to reimbursement issue. So, well, it was quite unquiet, and there was inconsistency between states in regards to regulations. That's right. In Europe, European Federation of Radiographers entered a discussion document and published a document. A lot of aspiration of technologists met roadblocks in some countries. So we have technologists tried to advance, but we were blocked in that country. EFRS. Why we talked about EFRS? EFRS is a really great strategic influence because it represents the professional radiography within Europe. It was established in March. 31 European countries are full members. More than, well, I don't know, 100,000 radiographers. As an educational wing, is a powerful lobby, and EFRS was really clear regarding what they did. And they don't want high-level conceptual document. So what's happened? We wanted to have an impact. EFRS asked us to work with them within this document, and we say, why not? Okay, they are radiographers, they are not technologists, but they can really impact the world of technologists, because in many countries, the education of radiographers and technologists is the same. So having a document that impacts nuclear radiographers may impact also technologists, and we wanted to do that. We started with some steps of cooperation. The first step was about MedRapet that we commented, is about a document about radiation protection all around. We were asked for details, and we discussed it. For the first time, we used the technology skill competence table, but a lot of contradiction arose. Okay, it was a first start, and that helped us to open a table for competence, because working together helped us to still start working together again. Here, where it comes, European Qualification Framework, the document from EFRS, the source of all the problems. Now I can tell you, was really a source of big, big problems. The first part was the optimistic part. Now I'm going into the pessimistic part of my talk. That's quite quite more impact on that. Well, actually, EFRS document represents a compromise, and not represent reality. For some countries, skills and competencies noted in the document were beyond the scope of faculty for nuclear medicine. For some countries, documents suggest less or lower skill and competencies. Possible question: what the value? Is the compromise? Is in the middle? What's happening? Here are some issues. Pathologies. Perform assess image in terms of quality, initial interpretation, diagnostic decision, make it complete the examination, and undertake all required post-examination steps. You remember our talk. This is advanced practice at the higher level. How you can state it in a quality that it's a really, really a strong statement. Administer contrast agents and other drugs. This brings a lot of contrast with the nurses because they are allowed to do that. And also with a lot of that is really strong advanced practice. So the situation was a document lacking detail. And the document refers to radiographers. But it's really unclear if they intend the text to be translated and applied to nuclear medicine. Can it? Should it? IFRS has defined umbrella entry level in nuclear medicine. But do all countries agree with the results? Well, we really fear that we have hit barriers in this project because we are really faced all these. And also the Association of Radiologists was really hard against this document. And now we ask, EQF6 is a consensus document. Well, working with FRS generate summit and resistance inside European nuclear medicine environment. Really, a lot of technologists from some countries really get upset of us working. Taiba remember. There was a really harsh discussion in Milan. It was terrible fighting. Tables broken, something like that. So it's a really quite a difficult situation. Not with doctors, with technologists. SNMI at that point said, okay, it's too much for us because we are talking about your political problem. We don't want to care about it. Okay, thank you. Goodbye. National regulations show it, but they were true. We got inside European politics. And it was really difficult to cope with. National regulations show it to be really discordant. And many European technologies doesn't feel and doesn't want to be represented by EFR. There was really a huge rejection of it. Barriers. What we can do? We are just 8 people. And there is a hit between radiologists and nuclear medicine physicians at now. We are living in a period of economic crisis. And lobbies are more power than what is discussion. I talked about it before. And we are really difficult to find the right partner inside the individual countries. While we wait, somewhere in Europe, oh, it's cleared. Oh my God, what's the problem with this? What's happening to my slide? What's happening to it? Just clean it up. Okay, difficult to see. I will talk about it. So there is a discussion, a document about technology basic competence, including hybrid imaging, what we want to do. The second will be a position document about technology basic competence, including hybrid imaging. I want to have an effort to be more involved with the European national societies, and an effort to be more involved in Central Eastern Europe project. That's what we'll do next. But the main, okay, while we wait, what's happening in Europe? I will talk about it, not using the slide. In Europe, no, finish. It's the last thing. In Europe, what's happening? We were discussing about how to advance, how to go up, how to go down, how to face process. What happened? That in Portugal, the government just decided to create a commission, stating, okay, you School of Nuclear Medicine Technologists are creating a lot of unoccupied paper, and they are costing us a lot of things. We create a pool of people to show if you are doing well your education. Which document may we use? EFRS document. So they took the document from the website and just stated the document was highly conceptual, not going inside the details of nuclear medicine procedure, and not going inside the details of other procedures like radiotherapy. And they decided not to have any more technologists, radiation therapists, and radiologists, but to join all together the education. Joining together education means that I've seen they take care of possible credit, and nuclear medicine was quite concerned. So there was thought they were preparing people going to work into nuclear medicine, working in nuclear medicine as a reliable practitioner, but they are not knowing anything about nuclear medicine. And that was happening, despite our discussion, despite our efforts. That's why we are starting to really work hard. And we are trying to involve EANM, ESTO, to really lobby things. Because while we talk, people, government in Europe, and maybe in other parts of the world, act sometimes in really bad manner. Not for professionals, but for patients. Because we are going to give patients in hand of people that are not prepared to do the right things. And that's what we are working on in the next days, and we will try to upload. Because we are really scared, and EANM was really scared. And there will be a discussion next weekend about it with all the national delegates. Because this situation scared not only technologists, but also physicians. That can be a starting point for having radiology and nuclear medicine physician together. And a lot of nuclear medicine physicians don't want it and have to fight. Thank you very much, and sorry for being so long.